Hello, my name is Witteles. I'm professor of cardiovascular medicine for the Stanford University School of Medicine and founder and co-director of the Stanford Amyloid Center. And today I'm going to be presenting this topic, unraveling the lineage, the genetic basis of familial ATTR cardiomyopathy. Here's my disclosures. So transthyretin, or TTR, the name comes from the function. It transports thyroxine and retinol, hence transthyretin. It's the same protein as prealbumin, and it's 127 amino acids. Almost completely, this protein circulates as a tetramer, as you see in the ribbon diagram in the upper right. So 4 subunits essentially bound together. But at any given time, it's in steady state with the monomeric form. And it's when thyroxine binds to it, it stabilizes the tetrameric form. It's the monomers that misfold and deposit as amyloid deposits. So monomeric transthyretin is inherently what we'd call amyloidogenic. That's what happens in the wild type form of the disease. But in addition, people can be born having inherited mutations in transthyretin, which make it even more amyloidogenic. We call that variant ATTR amyloidosis, and the predominant manifestations are cardiomyopathy, neuropathy, or both. And there have been over 100 different pathologic mutations described, and the mutation really matters because the mutation specificity correlates with the severity, the age of onset, and the clinical manifestations of the disease. Now, when you start looking at genetic mutations, it's really important to make sure you have your nomenclature right. And it can seem confusing, but I'm going to try to simplify it here. So when you do genetic testing, first off, it's different when you're sending off a broad cardiomyopathy panel, which can be sequencing dozens of different genes, versus doing specific genetic testing for the transthyretin gene, where you're just looking at that one gene. It's included in broad cardiomyopathy panels, but if you already have a patient diagnosed with ATTR amyloid cardiomyopathy, you don't need to send the broad panel. You can just sequence that gene itself. Now, when you get the nomenclature back, it might come back as wild type, or it might show a mutation. And if it shows a mutation, it can refer to it in any of 3 different forms. So I've listed on this slide 3 different ways of referring to the exact same mutation, which is the most common mutation in the United States, a valine to isoleucine mutation at position 122. So you can do it based on the nucleotide change, as you see in the first, which would read C.424G to A. You can do it as the amino acid substitution in the entire protein, which would be here P period V142I, or you can refer to it in the mature protein, which is after you've cleaved the 20 amino acid signal sequence. So here you'd say V122I. Importantly, this is all the same mutation. So sometimes this causes confusion. Somebody says, oh, I have a V142I mutation, and my family member has a V122I mutation. That's the same thing. Now, if you see a patient with a mutation, you're trying to get a sense of, is this pathologic or not? Again, there's many, many different mutations. So this is a very nice resource, amyloidosismutations.com. And it lists all of the known current mutations, and it's kept updated. This is what it looks like if you zoom in. This is one of the more common mutations we're going to talk about, the T60A, and you can see, again, the different nomenclature. So it shows the nomenclature. It shows what it's most associated with. So in this one, they're listing carpal tunnel syndrome and heart and peripheral nerve manifestations. It shows the common ancestry, and it gives you some references. Now, when you think about the mutations, it's important to emphasize that none of them are pure quote-unquote mutations, meaning that some will affect the heart more, some will affect the nerve more, but none of them are truly pure. Even the ones that are most neurologic in their manifestations can have a little bit of cardiomyopathy and vice versa. We're going to focus on these mutations here as the more common ones. And then, of course, at the bottom is wild type, which is the most common. But as this is a talk on mutations, we're not going to focus on for this talk. So V122I, as I said, is the most common mutation in the United States. Here's a number of different databases, and you can see into the thousands of patients. And they all show among individuals of African descent in the United States, somewhere around a 3 to 3.5% prevalence of the mutation. Now, it does not mean that everybody who has the mutation develops the disease, but the risk is substantially higher. If you look within Africa, you can see that the highest prevalence is in Western Africa. And if you look at the United States and North America and South America and the Caribbean, you can again see different prevalences of the mutation in different countries, but quite substantial in much of the West. When we think about how important this mutation is, there's a couple of interesting studies to look at. This was in the New England Journal of Medicine in 2015, and you had nearly 4,000 self-identified Black participants in the ARIC study. Now, ARIC was not an amyloid study. This was a longitudinal atherosclerosis risk study. But the nice thing was they had decades of follow-up for people. They had blood to genotype everyone, and they had other studies for many patients like echoes and biomarkers. What they found was that the mutation in the self-reported Black population was, again, right at that same number, 3.2%. It was virtually not seen in the non-self-identified Black population. And those individuals who carried the mutation had more systolic and diastolic dysfunction, higher NT-proBNP. And on echoes, 7% of the carriers had overt signs of amyloid cardiomyopathy. So it gives us a little bit of a sense of the penetrance. But that's a floor, because a lot of these patients probably had more subtle signs of amyloid cardiomyopathy. And also, others would have developed it with more follow-up. Here's, again, looking at the same group of patients from ARIC. They looked at the risk of atrial fibrillation and stroke over time. And you see a hazard ratio of nearly 2 for atrial fibrillation and over 1.5 for stroke. And the only plausible way that this mutation would cause a higher risk of these two outcomes would be by ATTR amyloidosis, the vast majority of whom were clearly undiagnosed. Here's another study looking at a different database from Penn Medicine, and you see that in this study, there was an odds ratio of 1.7 of having heart failure, or in a similar data set for Mount Sinai, 1.8. Once again, there is no plausible mechanism for V122I to be causing higher rates of heart failure other than by ATTR amyloid cardiomyopathy. With no doubt, most of these patients are undiagnosed. This was a very nice study by my Stanford colleague, Kevin Alexander, where he looked at national death certificate data where amyloidosis was listed as an underlying or contributing cause of death in the years that you see. What he found was that mortality rate from amyloidosis doubled over that time frame. Now, we don't think that amyloidosis actually increased. It's just that it was getting recognized more. By the way, after 2015, undoubtedly this accelerated even more so. He found that Black men had twice as high mortality rate to the next highest groups. That makes sense because we know that, again, the most common mutation is primarily in individuals of African descent and affects men more than women from a phenotypic standpoint. He also found there was tremendous geographic variability in diagnosis. And when you look at it graphically here, you see the proportion of Black residents per state on the left, highest in the South. And then you see the amyloidosis death rates by states, where you actually see the lowest in the South. And in fact, you see this, what seems to be an epidemic of amyloidosis in Minnesota. And the reason for that is because of the locations of amyloid centers. And over this time period, the biggest amyloid center in the country was at Mayo Clinic. And you can see that in the people who lived near Mayo Clinic, you had about a 6 or 7 times rate of amyloidosis listed on your death certificates as the national average. So what does that say? You'll only find amyloidosis if you suspect it. In terms of prognosis, we can see this is looking at patients with a wild type or non-hereditary disease versus the carriers with the patients with the V122I mutation with the disease. And you can see that for any stage of the disease, the outcomes are worse with a mutation. It's a more aggressive disease. Now, one interesting question is, does this mutation cause significant polyneuropathy? And this is still a question of some controversy. There's certainly no doubt that this mutation causes predominantly cardiomyopathy. And yet, statistically, you'll find that a lot of patients who get silencer prescriptions, despite in at least the first few years, silencers not being approved for this indication, come from the individuals with the V122I mutation. So how much neuropathy does it cause? And it's really important to differentiate compression neuropathy, so amyloid deposits that are compressing the nerves, causing things like carpal tunnel syndrome, spinal stenosis. We know this happens with all forms of ATTR amyloid, including wild type. And so when you're looking at something like ICD coding, sometimes that will get listed as a peripheral neuropathy, but that's not really what we're talking about. In addition, as patients get older, there's other important causes of polyneuropathy. So here was a study of V122I looking at ICD diagnoses from a number of databases, and it seemed like there was a very big association with polyneuropathy, but the absolute numbers were small. Look at the numbers of V122I carriers, 5, for example, in the entire UK Biobank for this study. And when you looked at the data, by age 75, V122I appeared to have a more population attributable risk for polyneuropathy than cardiomyopathy. That is simply unbelievable. And I mean unbelievable. That clearly is not the case. So it suggests that there's some problem with the data and probably how it's, again, being coded. So I'd like to actually look at the clinical trials. And if you look at major clinical trials, here was Apollo, which was a polyneuropathy trial. Only 2 out of 225 patients in the entire trial had this mutation that's otherwise the most common mutation. Same sort of thing in another silencer polyneuropathy trial. Whereas when you get into the cardiomyopathy trial and you look at the hereditary patients, over half had this mutation. So clearly it predominantly causes cardiomyopathy, at most a little polyneuropathy. The next mutation to briefly discuss is this one, V30M. It was first described as familial amyloid polyneuropathy. It's the most common mutation for causing polyneuropathy worldwide. Portugal, Brazil, Japan, and Sweden are the areas with the highest prevalence. And there's 2 distinct phenotypes: an early onset, which can cause a devastating early neuropathy, often in the 30s or 40s, or a late onset that typically occurs in individuals after age 50, which is more of a mixed disease. And interestingly, it seems like this correlates with actual different pathologic pattern, and whether the full-length transthyretin protein and C-terminal fragments are being deposited, or only the full-length transthyretin protein as well. Really fascinating pathophysiology that links what you see under the microscope or by mass spec with the actual phenotype of the disease. And then the last mutation to discuss is this one, T60A. It's most common in the UK and Ireland, and in the United States, any area where you have particularly high Irish immigrant population or historical Irish immigrant population, you see it. And this was a study of 60 patients in the UK as well as in Canada, and they found that 40 of the 60 had Irish ancestry. Interestingly, 5 had already received inappropriate chemotherapy for presumed AL amyloidosis, which shows how important it is to accurately diagnose your patient. And you see that about half the patients presented with cardiac symptoms, though almost all had signs of cardiac amyloid on echo. When it came to neuropathy, again, most patients have it with this, and it's a lot of autonomic dysfunction. And in particular, it's a lot of GI autonomic dysfunction. So lots of constipation, diarrhea, associated with this disease. Some of it is from direct GI infiltration, and some of it is from a neuropathy. If you look at the classic peripheral neuropathy, it's in about half the patients. So in conclusions, there's over 100 different known transthyretin pathologic mutations. It's really important to understand the nomenclature, and again, the phenotype really correlates with the mutation. For V122I, it's the most prevalent mutation in the United States with predominantly cardiomyopathy. For V30M mutation, it's the most prevalent mutation in many parts of the world. 2 different forms, but overall neuropathy always is an important part of this phenotype. And finally, T60A, which is the second most common mutation that we encounter in the United States. This is mainly in individuals of Irish ancestry, where cardiomyopathy and neuropathy often coexist about equally, and GI symptoms are quite prominent. Finally, I just emphasize we can do so much, and it really emphasizes the importance of making diagnosis and doing genetic screening. Now that we have therapies, it's really important to diagnose. I just want to highlight I'm the privileged to be a deputy editor for JACC Cardio Oncology, and we see ourselves as a home, hopefully the home of amyloidosis research, and we've had a couple of special issues that you might want to check out. And I just want to acknowledge the tremendous multidisciplinary team that we have at the Stanford Amyloid Center, and I thank you for watching this video.